One, and we are live. Please start, sir.
Good evening, friends. Welcome to the PG track program of Delhi CSI. The clinical pulse. We are into the case discussion series and to the fifth case discussion today. This is webinar number 63. We have been running successfully for more than a year. And today we have a case discussion on a patient with chest pain with a special focus on coronary artery disease. We have a great privilege of having Professor Rakesh Yadav, who is professor of cardiology at All India Institute of Medical Sciences. And we also have the privilege of having Dr. Kamal Sharma, who is senior intervention cardiologist at Sal Hospital and associated UN Mehta Institute of Cardiology from Ahmedabad. Along with me in this journey, we have Dr. Nitish Nayak, who will be joining soon, myself, Dr. Mohit, my colleague, Dr. Girish, MP, and Dr. Sumod Kurian, professors of cardiology from GB Pant Hospital. We also have our residents and fellows, four of them who have joined us. Today, our presenter would be Dr. Ajay Ram, who is a third-year outgoing fellow of cardiology from GB Pant. He will be discussing the case, some hygiene measures that I would be saying that Dr. Ajay, you can just present the case in flow. It will be discussed by our examiners, and you can feel free to express, answer. And any one of us who feels to answer, please raise your hand. Dr. Sumod will be moderating, and they can also be given a chance to answer. So practically everyone can participate. Also, all the people who have joined, already 200 plus waiting, I would just request you to just enjoy this discussion. In case you have any questions, comments, or clarifications which you need, please feel free to write us on the chat box. We'll be very happy to take all those questions and answer those queries for you. So without wasting time, please let us start the case discussion. In case you miss this case, don't worry, we'll be posting it on our YouTube channel of Delhi CSI, the PG Track CSI Delhi branch. You can download, read, reread, listen, re-listen to the same webinar whenever you wish to. So over to you, Dr. Ajay Ram, for presenting the case. All the best to you. Please go ahead.
Ajay, what you should present first history, and we will interrupt when you have finished the history. Then we will going to make our differential diagnosis based on history. Then your examination, then finish examination. Then we will not interrupt a lot in your history taking. Okay?
Is my screen visible, sir?
Yes, yes. Please
go.
Good evening, everybody. Today is the case presentation in the PG Track CSI Delhi. So today, the 45-year-old male resident of Delhi presented to emergency with history of acute chest pain associated with setting since 4 hours. Coming to history of present illness, patient was apparently normal before the onset of chest pain, developed chest pain sudden in onset while he was cleaning his home after returning from his work. It is retrosternal crescendo reaching to peak intensity within 30 minutes. It is rapidly progressive, heaviness in nature associated with nausea and sweating, and also radiating to the both upper limbs up to elbow joints. Pain aggravated on minimal exertion, and he didn't relieve on taking rest. He didn't take any medications for pain relieving at home. Chest pain not aggravated on deep inspiration or any postural variation or any movement of any neck and upper limbs. Then patient, in view of persistent chest pain for 30 minutes, reached to nearest government hospital, community health center, where the ECG was done suggestive of major heart attack like STEMI, and they have loaded with aspirin 300 mg and clopidogrel 300 mg and statin 80 mg, and they also given sublingual nitrate for pain, but didn't alter the intensity of chest pain. Vitals were in normal range at the time of the hospital in CHC. Patient been referred to tertiary care center for definitive treatment in ambulance. Here, the symptom of onset to first medical contact is 60 minutes. Then patient reached to GB Pant Hospital emergency approximately 4 hours after the onset of symptoms. Patient been thrombolyzed with thrombolytic agent, injection tenacity place as per the weight adjusted. Here the door to needle time is 30 minutes and the total ischemic duration of the patient was 270 minutes. He was completely relieved from chest pain after giving the injection, that is thrombolytic agent. Then the patient having no history of any shortness of breath, syncope or any palpitations, no history of any bleeding following treatment, no history of any fever, cough, myalgias, no history of any trauma to chest, no history of any unilateral or bilateral swelling of lower limbs, and no history of any claudication of lower limbs. Coming to past history, no history of any diabetes mellitus type 2, hypertension, no history of any coronary artery disease or peripheral artery disease or cerebrovascular accident, CKD, or any major surgeries in the past. Coming to personal history, no history of tobacco chewing or drug abuse. Patient had a habit of consuming tobacco in a form of cigarette, 10 per day for 30 years, almost 15 pack years. Bladder and bowel habits were normal, sleep and appetite were normal, and socioeconomic history, occupation, patient is cleaner in hotel. Family history, there is no significant family history of type 2 diabetes, hypertension, premature CAD, or sudden cardiac death. So to summarize, shall I summarize?
Yes. First summarize, then we will ask.
45-year-old male current smoker presented with history of acute chest pain since 4 hours. This is a Canadian Classification Society, Cardiovascular Society of class 4 angina, which was relieved by thrombolytic injection with no history of any breathlessness. So the most differential diagnosis, my first will be the CAD, acute coronary syndrome with STEMI with Phillips class 1. Then second possibility will be the aortic dissection, and third will be massive pulmonary embolism.
So first we will go to your history.
Yes,
You have correctly said that patient has a 4-hour history of chest pain. But the one thing very important, you have said that heaviness in character, nature. The chest pain is heaviness in nature. What do you mean by that? How will you describe a chest pain and heaviness are two different things?
the patient has told that he has feel that very high pressure within the chest, as if like a
There's two things. That's why it's very, very important. It is a compression in the chest, it is a chest pain, it is a heaviness, burning sensation. All are different way of presentation of rest angina. We have to be very specific. Why it is important? Because it will go in your differential diagnosis. One thing is when never happen in aortic dissection. And second important thing you told ki it is radiating to the both arm. Heaviness will never radiate to the both arm. It is only the pain which radiates to the both arm. Yeah, the heaviness has no character of radiation. It is a pain which radiates. So you have to be very specific. When you are presenting this history, you have to be very specific. Either commit is a heaviness or commit it is a pain.
it's a chest pain that is radiating, sir. Then
So don't use these type of thing that heaviness in nature, because pain. How you describe a pain? Tell me in medicine how will you describe a pain?
so in chest pain,
First,
onset of
any
pain,
any pain. Yes, onset.
the onset, the duration of pain, whether it is
Duration.
progression of the pain, then quality of the pain, then associated.
What do you mean by a quality? It's not a quality. It is a severity.
Quality of
You have to choose
You
word
mean to say
appropriately.
character or quality? You mean to say character?
character, sir, character.
So character is different from quality. So what sir is saying, its severity is graded. You know, you can grade severity.
Yes, sir.
How do you grade severity?
The severity of pain on visual analog scale from 0 to 10, we can.
That is one. Any other?
One by the other classifications from the Canadian Classification Society, from the NIHA, and also from the Goldman Specific Activity Scale. All this can also assess the severity of angina.
So basically, there are two issues with your history. One is that you have mentioned it very precisely, including the loading dose, including the lytics, and still in summary, you are putting a differential of aortic dissection. Lytics with a dissection. Do you think either you are too well informed about the history, which either is being told by the patient himself, he is too well educated, or somebody has told you that itna clopidogrel, itna thrombolytic, this many dose, this much window. You know, either this will not come from the patient, or somebody has given you the history, which is fine, in which case your differential of dissection just goes away. You can't lyse a dissection, right?
Sometimes in aortic dissection, maybe we have been with RCA involvement with MI, they have been thrombolized with without knowing that also.
Tell me which pain radiate to both the arm. Is aortic dissection and pulmonary embolism pain radiate to both? You have very specifically told it is radiated to the both arm.
Yes, radiation will be seen only in the coronary artery disease. Sir. Radiate with both.
Why? Why it radiates? Why pulmonary embolism pain usually don't radiate?
So it is about the nerve supply that is supplying the thoracic vertebra to from the nerve endings, that is the main cause for development of pain. Whereas in pulmonary embolism, the pain is due to central dilatation of the pulmonary artery stretching that causes the pain.
Is that the cause of pain alone, or pulmonary embolism pain can be something else?
Sir, massive pulmonary embolism, it is dilatation of central pulmonary artery. With
And-
small pulmonary embolism, it will be due to the pleural small infarct at the periphery of the lung that causing the pleuritis, that is causing the pains.
And what is the innervation for the fibers to the cardiac plexuses? What levels do they go? That's what sir was asking. Cardiac plexus has got what dermatome supply, or not the dermatome actually, what the cardiac plexus is formed by the vagal fibers from what joints, which nerve, what is the loop anatomically, and what does it supply and where does it go? Is C1 represented anywhere in dermatome?
No, sir, no, sir.
It's not represented. Why? Where does it go? What happens to first cranial C1?
So C1 doesn't supply side.
So where does it go? There is a C1 or there is no C1?
The C1 is there, but
Yeah, so where does it go? Cardiac plexus is formed by the vagal fibers, and on top of that, where does it innervate? How does it, what is the extent?
T2 to T6.
So shoulder is which dermatome? Both shoulders.
It's a T2 to T6.
No. You should know the. That's why
T
there is a
doesn't come
specific
here, T.
radiation.
This is all C. Longest finger, the longest vertebral. You know, that's how you used to remember C7 and C. So C, it's all C, not T. So you should know the dermatomes, ansa cervicalis, which is the C1, which goes into the forming the cardiac plexus. C1 doesn't go with it. And then the two plexuses join, and then there are two fibers from the left and the right, which innervate more fibers of the left going to the AV node, and the right going more to the SA node. Correct me, sir, if I'm wrong. So this is what I remember. Yes. Yeah, right. It forms a plexus. The right goes more to the SA node. Left goes more to the AV node, but then there is an interjunction between both of them. And then it's dermatome being represented up to T10. That's why the pain never radiates below umbilicus. You never have a cardiac pain going below umbilicus, 10 and C. So it's all those nerves. That's why the radiation takes place to them. So any other differential, you're just thinking in these two terms only? Are you relying too heavily on the dosaging and the lytics, and maybe you're, I mean, maybe patient knows this, or maybe you're allowed to have an access or such a fantastic history, which is like absolutely textbook history. Most of the times patient would not know what drug was used, what dose it was used, but it is good that when you describe a lytic and you're trying to bring out whom to lyse, whom not to lyse, it's fine for that point of view. Anything else that comes, assuming that you don't know that what lytic it is, or what it has been, what therapy has been given, other differentials that you can think of for the plane that you think of that it is happening.
So if I don't know the thrombolytic agent, if the patient doesn't show the history of thrombolysis, then I will think of the other two DD what I kept, or even sometimes a pericarditis pain can also be mimicked like an ECG showing ST elevation that can also be will keep, or myopericarditis as.
What is Levine sign? Coming back to pain. So you sir ne pucha tha aapko certain features. So there is site, character, radiation, intensity, timing, relieving, aggravating factor, origin, duration, and onset, right? So the acronym, just to remember in case you get confused at the time of exam, is script FADO. That's how I teach. S for site, C for character, R for radiation, I for intensity, T for timing, F for factors, aggravating and relieving, duration and onset. You remember everything. So script fat gayi to sab yaad aa jayega. So if you forget anything, script FADO includes all the acronyms that you can think of describing any pain. All right. So anything is what? Levine sign? What is Levine sign?
Levine sign is the patient will telling the history as if keeping a clenched fist over his chest. So that to describe the patient as having a cardiac angina.
And what is Levine's test? It's something on the same lines, you know. Relieving factor, which can also be used to relieve something else which sir is specializing in. Carotid massage, can it relieve angina?
Oh, sorry, it may be sympathetic stimulation, parasympathetic.
Yeah, parasympathetic and slowing of the heart rate. So that was Levine's test. You roll up the carotid and then probably patient can sometimes feel better. So that is Levine's test and this is Levine's sign. Okay. Pain description, can you be more precise? Classical, sir. Sir, aap kuch
Yes. No, bilkul hai. That is a very important. You have told it's an angina.
Yes.
Why it is an angina and what are the type of angina? How will you define angina?
So angina is in a Latin phrase that is meaning that patient having a choking in chest that has been described initially.
You say how you say that is an angina. It's a chest pain. It's a atypical chest pain. Sometimes you say there's a three type of chest pain.
It is a typical angina. It will be aggravated by an exertional or emotional stress, and the quality of the pain will be the constricting or heaviness, and relieved by taking rest or sublingual nitrate. All the three is present, then it is typical angina. If any of the two is present, it is atypical angina. None of them present, it will be non-cardiac chest pains.
And how will you define unstable angina? If there is a separate definition of unstable angina, is STEMI pain. STEMI pain should be classified with Canadian classification or not? Canadian classification is
Canadian
typically for what?
is actually for the unstable angina.
Canadian, then tell me the Canadian classification.
So Canadian
if it is for unstable, then tell me it's for unstable angina.
So it is.
No, it's for stable angina. And for unstable angina, what is the Brown-Wade classification?
Brown-Wade classification is A, B, C, sir. A means the new onset or accelerated angina in any patient within last 2 months. Then B will be the patient having angina, resting angina, but not last 48 hours before. Then C will be the resting angina within 48 hours. Then again the 1, 2, 3. Sir.
Okay, tell me. Okay.
Then the patient, depending upon if it is secondary angina, it will be B. Primary secondary angina, it will be the A, and B will be the primary angina, and C will be the post-MI angina within 2 weeks. Then if the patient on minimal angina or no minimal drugs, it is 1, and it is 2 will be the 1 or 2 anginal drugs, and 3 will be the 3 or more anti-anginas with maximum, even including nitroglycerin. That will be the Brown-Wade classification.
Yes. It was given by Brown-Wade in which year? You know it?
So Brown-Wade is given in 1960s. I think around 1970. I think, sir. I don't know.
No. So it's much later. This classification came in late 80s.
80s.
So late 80s. So this classification was given by Brown-Wade. So ideally, in rest in ACS patient, when your pain lasts more than 30 minutes, you should not classify with a Canadian classification. Second important thing, the question is you have told in negative history that unilateral or bilateral swelling in both in lower limb. What do you mean by that negative history?
Actually,
why you have taken this negative history?
Sir, in view of the history, patient may have some pulmonary embolism where the history of DVT. For that, I have taken that unilateral leg swelling is present. That's why I asked that. And bilateral swelling is for the cardiac failure if the patient having preceding any history of that or any pedal edema. That's why I asked that history.
So, you bilateral acute onset pedal edema or it's a chronic pedal edema?
Maybe chronic history that is relating that history. If the patient having chronic history, maybe the patient having prior any CAD or any patient having prior history of heart failure, that may be to rule out the patient having any right heart failure futures. For that only I asked that. Unilateral swelling is for the DVT to rule out any prior history of DVT. Maybe that goes in favor of pulmonary embolism. For that history, I used that unilateral history.
And the patient has also a history of sweating and vomiting. I think you have given an positive history.
Yes.
Why vomiting happens in ACS or STEMI or unstable angina? Why vomiting happens?
Due to the autonomic.
And second important question is, what are the atypical presentation of ACS? Answer the two questions.
Sir, generally, if the inferior wall of my patient most of the times associate with excess parasympathetic stimulation that causes the nausea and vomiting are more likely. Whereas in anterior wall MI, 50% of the patients will have excess of sympathetic stimulation that causing the more amount of sweating, diaphoresis that will, or anxiety, or sense of fear or death. All this sympathetic stimulation, neuropsychiatric manifestations are quite common with excess sympathetic stimulation that is seen in 50% of patients of anterior wall MI. And the second question is the atypical manufacturers of STEMI is the patient having pain other than the site of a chest. For example, pain at the jaw, shoulder, pain at the above the umbilicus at the epigastric region, or patient complaining of indigestion, or patient may have some cardioembolic stroke like complication. They can present like atypical feature of STEMI, or they may present like syncope, or they may present palpitations. They may present like indigestion. They may present like burning type of burning type of pain of esophagus.
So why there is a palpitation when you have an ACS?
The palpitations may be due to the excess sympathetic stimulation in anterior wall MI patients that can cause palpitations, or patient had developed any new onset of atrial arrhythmias in atrial fibrillation, or VT, or ventricular arrhythmias, or VPCs. That
Tachyarrhythmia, you should say tachyarrhythmia. What tachyarrhythmias are common during the acute phase of acute MI? ST elevation.
Tachyarrhythmias most commonly will be the up to 10% of patients can have the ventricular tachycardia and fibrillation, sir, in acute MI patients.
You consider sinus tachycardia as an arrhythmia or don't?
No, sir. Sinus tachycardia is the most common that will be seen due to
yes, number 8. Which is seen in how many patients? How much patient?
Sinus tachycardia, sir. Sinus tachycardia in sympathetic patients, up to 50% of anterior wall MI patients can have sinus tachycardia, greater than 50%.
No, it is more than 80%. Rest other arrhythmia?
Anterior wall.
Rest other arrhythmia? What is the incidence of atrial fibrillation, ventricular tachycardia?
So ventricular tachycardia, ventricular fibrillation will be seen up to 10% of acute MI cases, whereas atrial arrhythmia.
The MI which reaches the hospital, 10% is a huge number.
See, overall, I am telling you, up to 5 to 10%, sir, as per that study, Apex MI study, I think, what I remember.
And what is a sudden cardiac death in MI? As literature, what is literature says? How many patients do not reach hospital of stimulation?
Norris et al. Study, he have shown that almost 2/3 of the patients who had an two-thirds of the patients who had a death outside the hospital. Among this, the cause may be due to the CAD or arrhythmia. We don't know. That is the told what is, but Norris et al.
Majority of the is a CAD leading to arrhythmia. Can you tell me what are other arrhythmias can occur during MI? You have said tachyarrhythmia.
It can have an atrial tachycardia, atrial fibrillation can have, patient can have.
Why are we not discussing the bradyarrhythmia?
So bradyarrhythmias can also happen. With inferior wall MI, we can have sinus bradycardia type 1, type 2A, type 2B, type 3, complete heart block. All the sinus bradyarrhythmias can also be seen.
With anterior wall? Yes.
Hello, sir?
With anterior wall, do you get the bradycardia?
No, sir. Anterior wall MI can also have, sorry, infranodal block can be, the septal perforators of LAD has been blocked. Then in these patients can develop anterior wall MI, can develop type 2B heart block progressing into complete heart blocks, or even asystole, leading to a poor prognosis in these patients.
Any rhythm disorder that's actually sign of better prognosis?
Accelerated idioventricular rhythm that can occur in a patient, reperfusion arrhythmia, that is sign of better prognosis in patients.
What is the mechanism of AIVR?
I don't know.
You don't know. One more mechanism of vomiting, which you answered, was veratrum alkaloid-like substances, which are secreted in acute MI. So it's not just the parasympathetic, but also chemical induced, right? So that's one more hypothesis for vomiting in acute MI, which sir had asked you. That's one more cause you should remember. So it's not just mechanoreceptor, sympathetic, but also chemical.
And if you go to older studies, they say vomiting has a prognostic significance. If you have a vomiting in acute MI, it actually shows large MI or inferior MI. So vomiting, there are a lot of studies which is done in early 80s with relation of vomiting and nausea with acute MI.
Okay, just tell, let me take vomiting one more step. Do you know any vomiting causing an MI? A patient presents with retching, vomiting, young female, you do an angiogram, you find something classic and you know this is the diagnosis.
It is esophageal tear that will
No,
be.
no, not esophageal. We are discussing acute MI, dear.
Okay. Sir, vomiting के बाद
What is SCAD? SCAD, sudden cardiac death, nahi. SCAD.
Spontaneous coronary artery dissection.
Yeah. So what is the classical presentation? This is the classical presentation. Any strenuous activity, including retching, can trigger in young females. What is the basic pathophysiology? Why some people will, vomit buckets of it, but still not get MI, but some will. What is the basic disorder that these patients who end up with spontaneous coronary artery dissection and MI, what is their genetic abnormality that they harbor across their vascular structure?
So these patients, majority of them are younger females, have associated some.
That's fine. What is the problem?
Dysplasias,
Yes, that's more important. Fibromuscular dysplasias are something that you need to rule out in these patients. If you have a patient who presents with retching, vomiting, ends up with spontaneous dissection and an MI, then you need to rule out FMD. Correct. So that is one thing. So sir had asked you vomiting. Could we pull into that? So once you have got the history of chest pain, which you have described as heaviness or retrosternal, and can you name some of the syndromic, two questions. One, normal coronary is still classical angina causes. And second, some anginas which are classical by their description or their names, and you know what you are dealing with, pure based on history.
Sir, if the patient having angina but coronaries are normal, that is most commonly seen if the patient having microvascular anginas or patient having coronary spasm.
Is that the cause? So Minoka, that is one that you are saying, right? MI. What is Minoka? Full form for?
Myocardial infarction with non-obstructive coronary artery.
That is one. Second, normal coronary is patient has classical angina. What are things to rule out?
Coronary spasm can also be seen. Patient having
no spasm, no MI, TROPS negative, classical angina, no MI. Now? So it's the same question which I've asked you in a twisted fashion. This question, if you were presenting a valvular and I had asked you, you would have given me 10 lists, but if I twist the question.
Then it may be non-CAD causes, it may be valvular heart disease like severe aortic stenosis, left ventricular outflow tract obstructive causes, then RVOT or right ventricular outflow tract obstructive causes, or any embolism can also cause from this valvular heart disease patients can also.
Okay, so from history, so that's fine. Now you've got the question. So from history, can you tell me this history, this kind of angina, this is likely as the etiology. Can you tell me some of those histories which goes classical with some of the diagnostic value of cause of angina? Most of them will come with names. I've given you a clue. What is Fidipides angina? Under what of Fidipides? Who was Fidipides? Greek mythology. Athletes angina. Fidipides was, it is supposed to be the Athens war breaking out, and he was a runner who ran across to the country, to inform that the war had broken out, and as soon as he gave the news, he collapsed. So angina of athletes with normal coronaries, or maybe he was harboring some disease, but that's how the name has come for athletic angina, Fidipides angina. Any occupational angina you know of? Again, from history, this patient.
Variable threshold angina can also have occupation where some days patient have angina, some days patient doesn't.
Occupational angina. Occupational angina is related to one of the occupation. He works in somewhere and then he doesn't go to that place and he gets angina. He goes to there, he feels relieved. So he gets angina on the day he's resting. Ammunition workers. Nitrates can be absorbed through skin and that can get relieved when they're working. That's occupational angina because of nitrate not getting exposed through the skin in the older days. Of course, now you have the protective gear. You can get angina. Any other angina which is precipitated by something, precipitated by meals, and you suspect this as the cause. Precipitated by meals, worsened by nitrates.
So, precipitated by meals. If you take a patient postprandial angina where the patient.
That is one. And something else, worsened by nitrates. Which are the Nitrate worsened angina.
Prinzmetal and oh no, sir, sorry, sir. No.
HOCM?
HOCM can worsen, sir. Yes.
So HOCM
Any-
usually you may have with worsening with meals, and you can get worsening with any other angina that where the nitrates are contraindicated.
Okay.
Patient has got acute MI, you don't not like to give nitrates.
The inferior wall MI be associated with RVMI.
RVMI, okay. Any one more angina, you don't want to give nitrates.
If the patient having blood pressure on lower side, then
Okay, pain other than angina relieved with nitrates. Patient has taken
esophageal spasm can also be relieved.
1 second.
Sometimes.
So, you might be prepared with the recent advances, current guidelines, COVID and acute MI, published papers of the profile of young CAD in Indians in IHJ, but, examiner can always go back to, a decade back and pull you for all these kind of questions. So biliary colics, esophageal spasm and acute MI, all three get relieved with nitrates. Nitrates are contraindicated in HOCM, inferior wall MI, and also sometimes in aortic stenosis or pulmonary stenosis associated angina. So these are the anginas where you will not give nitrates. Other anginas, of course, Prinzmetal, there's a difference how I need not discuss that. You should know Fidipides angina, some of these are occupational angina, certain named anginas, which again are specific for their profile, like HOCM getting worsened with meals. Sir, आप कुछ कह रहे थे sir? Yadav sir.
No,
HOCM.
Any LVOT obstruction you can say, but classical HOCM. One thing, should you give nitrates when you diagnose patient has an ST elevation MI? Rest when is more than 30 minutes. Should you give nitrates? What is the current recommendation? In all patients, it should be encouraged, discouraged.
So we can give for the relief of pain, we can give the nitrates.
Sure. Are you sure? Can you advise a patient on telephone that he's having 30 minutes chest pain and you will advise him? It's recommended, it's contraindicated, it's not be given.
We don't know the basic underlying ECG, whether it is an inferior wall MI or RVMI or anterior wall MI, sir. I don't know. If it is a patient having vitals stable, patient BP is good, fine. Of the patient having a prior history of past episodes of angina that is subsiding with nitrate, at those patients I can advise him to take the nitrate sublingual.
You should not advise them blindly. That's the most. What is the recommended therapy of acute ST elevation MI when patient is at home? What are the drugs and how you should advise patient? If you have to give a public lecture, that if you have a severe chest pain, what you should do? What is the recommended?
Sir, he can take the nearest aspirin. He can take, sir, the one chewable tablets, sir. It is 4 tablets, 75 mg. We can take the 4 tablets that is chewable, non-entry coated. I can advise him to keep with him in any patient who having a risk factors of CAD. Then
Yes.
I will also then advise him statins also, sir, for him. And if the sorbitrate, only if the patient having a chronic prior history of angina episodes, I will advise him to sorbitrate. But a first episode that is common in young patients, which is rapidly progressive, we don't know what the type of MI. It is unlikely to advise him with the sorbitrate or these patients. Then clopidogrel, there is unlikely.
No, at home you don't prescribe clopidogrel.
Unlikely to advise.
When you have to give clopidogrel, what is the current? Suppose patient reach hospital.
Yes.
What is the recommended? When you will give clopidogrel?
Right now, the recommendation of all the P2Y12 inhibitors can be given only if the patient is clopidogrel can be given if the patient is planning for primary PCR thrombolysis. We can give, sir. There is nothing with it.
At what time patient reached? After what investigation? What diagnosis? What is the recommended? In all patients of severe chest pain, you will give it.
And we will give the aspirin and statin if you don't know the coronary angiography.
No, statin is not recommended. What before ECG? What is recommended?
Before ECG, only aspirin, sir. Only aspirin is recommended before the ECG, sir.
Then you have done an ECG.
Then ECG, then I will load with the aspirin.
It is only ECG. It is only ECG. It is only ECG.
So if only ECG, if I diagnose with.
No. You have to do a clinical examination. What you have to rule out? Well, you just go and read the classical Recommendation. A patient of severe chest pain came to casualty. You have to do ECG within 10 minutes.
Then I will do the troponin can be done cardiac biomarker.
Troponin in 10 minutes में आधे घंटे में क्या आएगा? You have to examine all the pulse to rule out the aortic dissection. Then you will give clopidogrel and statin, depending upon you want to take to primary PCI or thrombolysis. Correct or not? Suppose he has given 300 milligram clopidogrel. If he has done a correct thing,
Yes, sir. We cannot give. If the patient having pulse VB discrepancy, if we are suspecting aortic dissection, we can't give that.
One more thing, sir is asking 300 versus 600. No, will the loading change if the plan is something else?
Sir, if the planning for a PCA, we have to give 600 mg loading dose for clopidogrel, sir. If you are only for thrombolysis, 300 mg is enough.
suppose he has given ticagrelor or prasugrel. What is the current status of these two medication for thrombolysis?
So ticagrelor can be given as per the treat trial. Ticagrelor can be given. So prasugrel is not recommended, sir. As per the trial, the ACS trial, where prasugrel giving that associated with increased
This
bleeding.
trial is what they have recommended in that trial. It is a safety study, efficacy study.
It's a trial, the ACS trial as well as showed that the prasugrel is associated with increased bleeding events without.
No. With thrombolysis. With thrombolysis, ticagrelor. What is the current status?
So ticagrelor can be given in patient with thrombolysis, sir. But given
which study has shown that it is the only study which is present is a safety study. It is safe. That's all.
Okay.
So is it coming the recommendation that with ticagrelor you can do thrombolysis? If the patient is to go for thrombolysis, if it has come with recommendation or not?
So I didn't get this.
Is ticagrelor is recommended for a patient who is only for thrombolysis?
So now it is recommended, sir. We can give the ticagrelor, sir.
Sure.
But prasugrel is not given, but ticagrelor can be given.
अभी recommendation में तो नहीं आई है.
It is just a safety study. What sir was asking, sir even hinted you. It's a safety study. It just says if the patient ends up with a lysis, then ticagrelor does not increase the bleeding incidence.
The bleeding is.
Yeah, it is not an efficacy study. It's a safety study. Prasugrel does not even have a safety study. So what sir is saying, it's only clopidogrel.
Can you, by a history, can tell which territory, which vessel is involved?
History, sir.
Your history and clinical examination, no ECG. Guess it. Can you guess it? These are things are there, so I can say it is an inferior wall or it is an anterior wall.
If the patient having excess parasympathetic stimulation, where the patient can have hypotension, bradycardia, where this patient presented with excessive nausea and vomitings, that maybe this patient can have an inferior wall MI. Or if the patient presented with excessive sympathetic stimulation, where the patient having profuse sweating episodes, with nausea will not be so much significant, then I suspect it may be due to the anterior wall MI.
Or if patient has an acute heart failure, usually what you suspect?
The acute heart failure is primary to the gross severe LV systolic dysfunction, that most commonly secondary to anterior wall MI, first option.
Large. Okay. If patient has atrial fibrillation, what is the more chance?
Atrial fibrillation also most commonly associated with inferior wall MI.
Why?
So atrial fibrillation because associated atrial infarcts will be there, sir, almost.
Yes, because atrial infarcts, the atrial infarct will precipitate atrial fibrillation more.
Can present like a new onset of atrial arrhythmias in this patient.
What are the causes of chest pain during MI and post-thrombolysis, successful post-thrombolysis? Is only damaged myocardium or something else also?
During the MI, it is due to the indicates that the myocardium is ischemic or injured, sir.
Yes.
Then after the MI, then the patient having a pain, it is due to the reocclusion of the culprit vessel, or it may be due to the pericarditis that is causing the pain.
Or but it is not only reocclusion.
or it may be due to the progression of the ischemia in this vessel.
What does it mean? Suppose it's a successful thrombolysis, an ongoing chest pain.
Yes.
Usually you see patient will have a mild ongoing chest pain. Why it is so? You have opened the arteries, the thrombolysis has opened the arteries.
So it may be because of this patient having associated collaterals or ischemic preconditioning will be present in some patients. That will be
Preconditioning का तो नहीं होगा ना.
Mild pain.
What is exactly it is known as? Microvascular dysfunction. Instead of you have thrombolized patient, you have more microvascular dysfunction depending upon the duration of ischemia and the perfusion. So microvascular dysfunction will lead to MI. Pericarditis will lead to MI. And what is the current percentage of VSR during MI?
So ventricular septal rupture is almost 1%. It is almost 1% of all.
1% is sure.
It will be seen up to 1% of all acute MI complications.
1 to 3% was in the older era. 1 to 3%, what you're saying is mentioned in Brunwald as the older era. Now it's not 1%. In that modern era of invasive, the incidence is lesser.
Kamal, should we go to examination?
Yes,
I think
yes,
40 minutes. Yes, go to examination.
So coming to general examination, patient is conscious, cooperative, well-oriented to time-place person, is height of 160 centimeters, weight 58 kilos, with body mass index of 22 kg per meter square, no peripheral signs of atherosclerosis, no signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. Temperature is 98.4 degrees, respiratory rate 14 per minute, thoracoabdominal, pulse is 70 per minute in right radial artery, regular in rhythm, normal in volume and character, no radio delay, no radiofemoral delay, all pulses are equally felt, arterial vessel wall is not thickened, and blood pressure in supine posture is right upper limb 110 mm of mercury, 110 by 80, right lower limb is 120 by 84, and left upper limb will be 114 and left lower limb is 120. JVP is not elevated with normal waveforms and no hepatojugular reflex.
Only tell me what is a current recommendation of measuring the blood pressure and writing the blood pressure. And second, do you get a difference in diastolic pressure in arms usually? Suppose there is a mild stenosis of left subclavian. It will lead to decrease in diastolic pressure also. So you have, because your all four limbs have different diastolic pressures, upper limb. And how will you write? What is the recommendation? Should you write 114 millimeter systolic?
The current recommendation is to write at least we have to check BP in one upper limb and one lower limb.
How you write it? You write 124 or it should be written as 125?
So it is, we can write as even numbers 140 by 90.
Now the recommendation is, because there's a lot of variation, you should go in number 5. Write it 120 or 125, 130, 135. If it is less than 2, 130. If it's more than 2, then 5 will have to be written. So now we never write. It's a recommendation now, because they say it's so variable that you cannot write 114. It should be within 5 millimeter. It should be written. And how you feel a vessel wall? You have say arterial vessel wall is not thickened.
So vessel wall can be palpable, sir. By means of 3-finger method, we can see that the thickening of arterial wall is present or not. We can see.
How will you see? Artery to feel ho jayegi.
Arterial will be easily palpable, will be having thickened, it will be rigid, sir, not like it will be not rolling.
So how do you do that? How do you feel that? Cord-like, that's how it should be. So you'll have to do with 3 fingers, 2 maneuvers with 2 fingers and 1 maneuver with 1 finger. Yeah, what is that? How do you do that?
In oscillars maneuver, we will inflate the blood pressure cuff of right upper limb and inflate it such that radial artery is not palpable. Then we will palpate the artery, sir.
No. If it is, if the BP cuff is not available and you want to demonstrate cord-like structure with 3-finger method, what will you do?
In 3-finger method,
and what will the 3rd finger do?
So 3 fingers will compress the proximal finger and distal finger, both will compress the arteries, sir, so that there will be no flow, and the middle finger will be useful for palpating the arteries, sir.
Okay. What is the peripheral stigmata of CAD? What are the examination you're looking at? So what are the things that you need to rule out? 1, 2, 3, 4, which will pick up a, peripheral stigmata of
patient. Peripheral signs of we can have that arcus analysis can be seen.
That is 1. Number 2.
earlobe sign, that Franklin sign can be
Number
seen.
3.
Then 3, patient can have radial artery thickening, that is Monkeberg sclerosis, where the patient
Fourth.
can be. Then patient can have xanthomas, xanthelasmas can be
5.
seen. Apart from this,
बहुत है 10-12 है, हम लोग को क्लासिकल पढ़ाया जाता था.
peripheral arterial disease can also have feeble pulse.
Okay.
Start with eyes, ear, skin, सबसे शुरू करो ऊपर से.
Head. Something on hair. Hair.
Sir, hair
Are there any
premature
papers
graying
on
will
it?
be there.
Sorry.
Premature graying, I don't know exactly.
Alopecia, androgenic alopecia. There are now a lot of papers. They are talking about meta-analysis, classifying it young androgenic alopecia, thinning of hair, premature graying. So all 3 they have been looked at into, but some have mild, some have moderate, some have strong. Alopecia has something which is strong. Or niche, sir, bol rahe hain. Come down.
काले काले होते हैं, कैंथोसिस निग्रिया को भी मानते हैं कि
True.
एयर लोब्स को भी मानते हैं.
Hairy pinna.
Where the patient can have gangrenous changes.
And what more? You have some autoimmune disorder also.
In diabetes, where
Peripheral markers of rheumatoid arthritis, gouty arthritis, they are all prone for CAD. So they are known as clinical peripheral markers of atherosclerosis. Central obesity is also a clinical marker of.
Coming to that, yes, sir. BMI, do you think this is, you are happy with 22 or you'll need to see at something else? Is BMI good enough for Asian Indians or something else matters?
Yes, sir, in Asian Indians, the BMI will be normal, or up to 18.5.
23 below is cut off for Indians, 25 wo theek hai, but BMI is the sole marker or something more?
Only
is the
thing
bigger
or
marker?
what thing?
Sir, we can also see the
What more measurement you should also perform?
One more measurement of CAD case.
waist hip circumference. I have to take it actually.
Is it ratio or the pure circumference which matters more?
So waist circumference and also waist hip ratio, sir.
Not the ratio. In Indians, it is the circumference which matters more.
Circumference is important. It is
Yeah,
greater
because
than
it's a
90 and
centripetal
80.
obesity, intra-abdominal fat. There have been studies, no? There are the 2 endocrinologists they have compared, Indian endocrinologist and American both had, and they licked the fat scan and look at the fibro scan, and they found out the proportion of, for the same amount, you had more lipophilic tissue in the abdomen, including the omentum, and hence it's more atherogenic, more prone to diabetes, pre-diabetes, metabolic syndrome, and hence more incidence of CAD. Being Asian Indian, do you think is a risk factor?
Yes, sir. In Asia, if the patient having increased weight circumference.
Indian. So I mean, suppose an Indian migrates to US and he adopts American lifestyle, American food, American, American air, American water, American diet, everything.
As per that, one study, that is Masala study, where it had shown that in this risk factors only cholesterol has been taken, and also it doesn't include that waist hip ratio.
No, not waist hip. I'm talking about is being Asian Indian. There is a editorial.
It's high risk.
जिसके सर editor हैं, उसमें पूरा एक article है. Asian Indians themselves being is a risk factor twice more than Caucasians for their counterpart, with occurrence of 10 years earlier of premature CAD with diffuse disease with multivessel. Pura paper hai. There you can go through in IHJ. There is a good article in that. And there, INAS's paper, which they have compared, there is a big study also. INAS has compared how the outcomes are different, Caucasians versus Indians. So you should know that also. How the Indian specific parameters can be variable for the cutoffs, and why the new guidelines talk about lower lipids. What lipid profile abnormalities are typical of Indians compared to Caucasians?
So Indians will have triglyceride will be more and HDL will be less.
With not such a high.
Crude answer. That is a very crude answer. There's a lot of more things are being given.
Couple of more things.
Now you should go beyond triglyceride and HDL and LDL.
Absolutely.
Lipoprotein A levels are also elevated. More
what percentage of Indians have lipolittle elevated? 33%. 1/3 of the patients will have lipolittle elevated in Indians. And what is lipid tetrad index? What about ApoA, ApoB? What is low, small dense LDL? What is high dense LDL? And how does it? What is its variation again amongst Indians? Small dense and large buoyant. And because you can't do chromatography for every lipid profile, So what is the reflector in a lipid profile to analyze ki jo LDL, whatever you are seeing is small dels or large buoyant? Is there some ratio which you can simply look at a crude lipid profile and pick up this is large buoyant, this is small dense?
Yeah.
TG by HDL ratio. If TG by HDL ratio is more than 3.5, you are dealing with a small dense LDL. So same LDL values is more atherogenic if your TG by HDL is more, because that reflects your. There is another paper on this that you can again go and read. So lipid profiles, BMIs, peripheral stigmata, Indian profiles, how, acha, between Indian, Pakistani and Bangladeshi, do you know any scoring system which looks at these three country nationality and profiles up who is at more risk? Who is among the three races more? It's not a racial difference, but there is one scoring system which is used to analyze where they choose your nationality from their database from the country that they migrated, and they give a differential relative risk scoring for them. You know any scoring system? Predictive scoring systems, you know, for CAD? How many of them do you know?
So one Framingham has.
Yeah, so that is one. Everybody knows it. Now tell me 5 more. And which one is best for Indians? Another paper again from Indian Art Journal, published in Indian Art Journal, written by Medanta Group. Dr. Bansal had written that paper, Dr. Manish Bansal's paper. They've compared JBS, QRIS 3, WHO, and the Framingham, and they've shown out which one works better. You should know that JBS works better. Another outcome of what I'm saying is QRIS 3. In QRIS 3, when you go and analyze, they will ask Indian, Pakistani, or Bangladeshi. Bangladeshis are more prone than Indians, and Indians are more prone than Pakistanis. So again, it's a Caucasian shift, you know, population, how they migrated, that's what is argued. The difference is very minuscule, but it allows you to choose nationality and how the racial differences can exist. Any interstate differences that you know in CAD prevalences? Interstate, Punjab versus Kerala, Tamil Nadu versus Gujarat, any data that you know of? Which state is more prone? Why? What is the profiling? Again, there are papers in Indian Art Journal.
So basically, when you are presenting the case of coronary artery disease, you should be knowing these all things, because these questions should be noted, because majority of the time you will be asked these only things, because there will be nothing in examination and the history is very brief, only chest pain. So you will always be asked in a coronary artery disease patient these all things. So at least you should know these all things. We are not supposed to know that you should know in detail of each and every study. But you should know what are the risk factor, what is the difference in India, what is the difference in regional variation. You should know the prevalence. That is very important. Always you will be asked prevalence of CAD. So if I ask what is the current prevalence of CAD in India, it depending upon the states also, so which is the minimum prevalence and which is the maximum prevalence, and what is an average prevalence of CAD in India. 2017 data, I think. The recent ICMR study, it's 2017 or 18 data. That is very important. What is you read, what is an annual incidence of STEMI in India?
As per the CREATE registry, sir, what is published in 2009, where the
CREATE registry to एक localized data ना. India में कितने STEMI patient होते हैं per year?
Almost 15 lakhs per year, sir.
No. You should be approximately 10% plus minus. You should not go 300% plus minus. How many patients in India get primary PCI?
So in India, it is around 8 to 12% on 2 different studies. It is 8% in the 12% in Kerala SS registered study, and CREATE registered study it is around 8.4%.
The average only 10 to 12% get primary PCI. So you go to more examination. I think you have 1 or 2 more slides on examination.
So in inspection, the chest appears bilateral symmetrical, nothing normal. So visible apical in palpations at the left inframammary. Rest of inspection were normals. Then palpation also, I didn't see any abnormal finding. Apex bit is palpable in left fifth intercostal space, 1 centimeter medial to midclavicular, localized LV type apex, normal in character. No palpable heart sound, rub and thrill felt. Percussion also, upper border corresponding to the liver with right fifth intercostal space, and left outer border corresponding to the apex, right hard border corresponding to sternum, and left second intercostal space resonant throughout. In auscultation, S1 is soft, S2 normal, S4 is heard at the apex, and no clicks, ejection sounds, pericardial rub, or murmur heard about the precardiums. In other systems, respiratory system, abdomen, CNS are normal.
Tell me, what are the various abnormal heart sound you may encounter without any mechanical defect post-MI?
So first, that S1 will be soft, that may be due to the increased prolongation of PR interval.
Commonest amongst them all.
So commonest will be the S4, sir. S4 will be present, that is universal in most of the patients with MI. Then S1 will be soft.
Recordable, audible.
Sir?
S4 is recordable or audible in most?
S4 will be palpable most when compared
No.
In post MI, will be audible, sir, when compared to palpable.
No, it is recordable more.
Recordable. It's
Recordable
so
10
soft.
to 15%.
Why is it? What are the hemodynamic equivalents of S4? When you have S4, what is LVDP? What is cardiac index? What is ejection fraction?
So if the patient having S4, it is most likely due to the pressure wall conditions associated with decreased
No. I am asking, give me values in absolute numbers. S4 is equal to LVDP more than this number, EF more than this number, LAF. Yeah?
LVDP greater than 12 in S4.
Sure? It's not 12. It's much more. What is EF? For S4, what should be the EF?
EF will be...
You should know. S3 mein, LVDP.
S3 mein severe systolic dysfunction. EF less
No. EF how much?
EF less than 40. Sir.
Correct. And EDVP more than?
LVDP greater than 18 to 20. Exactly.
This you should know. These are mentioned in a lot of books, including Joule's constant, which people controverse. But there are papers onto it, so you'll have to accept those numbers. 25 of EDP, etc., etc. Okay. Go ahead. Again, examination. So you had, sir was asking you, other sounds. First become soft. Okay. P2 can be loud for the mechanical issues. S4, S3 sometimes, rare usually, and then you can get cramps. Tell me this one physiological condition where all the sounds are heard. S1 is heard, S2 is heard, S3 is heard, S4 is heard, and you are okay with it. You don't have any problem.
Physiological condition.
I have given you a clue. It's a physiological condition, not a pathological. You're not worried. It's normal.
In young patients.
In pregnancy. Pregnancy, you'll get all of them. Okay. You can get all of them, but that's of course you're not worried about it. You can, in pregnancy, you can get S3, you can get S4 also. S3 of increased volume, S4 sometimes may be heard as well. Okay, so come to your diagnosis.
The final diagnosis is a case of coronary artery disease presenting with acute coronary syndrome, ST elevation, myocardial infarction, with 4 hours 30 minutes for definitive treatment in the form of thrombolysis with injection 10 plus according to body weight. Thrombolysis was successful, pain relieved. Phillips class 1, sir. Cause may be atherosclerosis with risk factor of smoking, with normal sinus rhythm, with no features of any embolic and bleeding complications. Hello, sir.
Will you call him young CAD?
Yes, sir.
How do you define young coronary artery disease?
Sir, in a recent article 2017, they showed that age less than 40 years, they are considered as a young CAD. Sir. Even some articles they are considered up to 45 years also.
What is the profile of young CAD? Any paper that you know of?
Young CAD in recent Tamil Nadu STEMI program has conducted Alexander et al. A sub-study has been done that has been published in a year back, where young CAD patients, where most of the times will be having a sudden in onset without any prior history of angina episode with rapidly progressive MI, and young CADs, mostly 90% of them are commonly seen in men when compared to women. Most of them are single vessel disease. LAD is most commonly involved.
Risk
And the patient will have the risk factor. Smoking is the most common risk factor, whereas females, it is diabetes, hypertension, dyslipidemia is the most common risk factor.
What is smoker's paradox? Smoker's paradox. What is obesity paradox? What is alcohol paradox? 3 paradoxes.
So after quitting the smoking, the patient...
No. Not quitting. When he's smoking, there is something. Are these 3 risk factors or no? Is alcohol a risk factor?
Yes, alcohol is not a risk factor.
Sure.
Sure.
Inter-heart study subgroup, Indian data subset.
If they have heavy alcohol consumption
In
then
India, what was the subgroup from Indian data? World over, yes, moderation was beneficial compared to heavy drinkers. Compared to heavy drinkers. But amongst those non-drinkers, what was the moderation is to be encouraged? I mean, those who don't drink should start drinking, or
no, sir. It is not advised. That is.
and what
only
about
one
Indians?
drink.
Does that translate into Indians as well? The Indian subgroup data was analyzed separately, including a paper from IIPGH.
Indians, women will have more.
So it was actually a risk factor. If they drink, because India mein what do they drink most of the times?
They will have cheap liquor. That is.
Yeah, cheap liquor. So it's a risk factor. Actually, it's a risk factor. So alcoholic paradox. What is alcohol paradox? This is the paradox. You know, moderation prevents that's alcoholic. Obesity paradox and smokers paradox in CAD. Also called as French paradox. So which is French paradox?
A lot of paradox in CAD now. Smoking paradox क्या है बताओ?
हाँ वही पूछ रहा था सर मैं इससे.
Yeah, that is.
Paradox.
I didn't hear, sir. First time.
They get more MI, but they don't die. They die. The
Why?
mortality is less.
Why?
So mostly in young patients who have will have the smoking, where the plaque erosion will be the most common. That will be so that will have the high chances of getting survival when compared to plaque rupture. That is most common in Western population.
So what responds and what doesn't respond? When there is a erosion, what will work compared to rupture? Which therapy is very effective in erosion?
Sir, in plaque erosion, we will treat with conservative as per the erosion.
No, not conservative.
If the patient having stenosis less than 70%.
That is fine.
In which patient, smoker, non-smoker, thrombolysis is more successful?
Yes.
And why?
I didn't get the question, sir. Which
Suppose you are a smoker and other person is non-smoker. The thrombolysis is more successful in smokers and non-smokers. There are a lot of data on this.
I didn't study it.
Usually, what is the lipid level in chronic smokers?
So it will be on lower side only, sir. But I don't know. But within the normal, not in a high normal, not in abnormal range. It may be most likely within normal range.
So you should know all these three paradox: smokers paradox, obesity paradox, and French paradox are also called alcohol's paradox. Okay, so PCI you have done. Can you, imaging wise, can you give me cutoffs? What is the definition of thin cap fibrous atheroma, TCFA? How do you define TCFA?
Thin fibrous cap atheroma if it is less than 65 microns. Sir.
What is its prognosis?
So thin fibrous cap will have the high chances of getting plaque rupture and future having risk of getting acute coronary
So
events.
in Gregstone's series, which is published now in Brunwald, what are the best predictors for a so-called vulnerable plaque? Now the definition is changed. Vulnerable plaque now is defined something else. What is that? What is that? There is a chart given on the right side page in the Brunwald, big one bar diagram.
So
Three parameters. One is TCFA, correct? Other two?
Another lipid-rich core, presence of lipid-rich core.
No. So you should read that. See, CAD you are reading, and Brunwald's slides, if you don't know, including the diagrams and pictorial pictures, which the examiner also doesn't have to read the book. He just goes through the table and knows what it is. TCFA, plaque burden, and MLA. So those three predictors, when you combine, that's the best predictor, right? And that's why it is important, because every day now everybody is doing imaging. So when you're doing imaging, that's how you need to define plaque erosion. Any paper that you know of, plaque erosion, you need to stent, you need not stent.
As per erosion study, we will treat manage conservatively. So this patient with
what was the outcome?
Stenosis less than 70%. That 1 year outcome, the patient has free from any cardiac events up to 1 year.
Similar to stented versus non-stented, correct. And advantage was not giving prolonged DAPT. That was the advantage. You can discontinue DAPT earlier as compared to in the erosion study. What is virtual histological criteria that define? Again, you were talking about lipid core, etc. How do you pick up macrophage? What do you mean by macrophage? Can you see actual microscopic macrophage in the IVUS, or is it something else you would mean by macrophage? What is macrophage?
Macrophages are the cells that has been infiltrated
No,
into
no, no.
the intima. So macrophage will have the lipid engulfed, having foamy macrophages that we see in the atherosclerotic plaques. It will seen like in a hyperdense in the OCT. Sometimes it will be seen.
So they are not the microscopic macrophages that you otherwise see, right, in microscope. So what do they represent? Macrophage is a good marker or bad marker? When you see,
No, sir, it is suggestive of active inflammation. This patient will have, this will be chances of vulnerable plaque, have chance of getting rupture.
right. So you've put this patient who's done a PCI. How long a DAPT would you give? You'll take from angiogram or you will not do angiogram for this patient. Let's discuss that. Patient is class 1. You have lysed. You've done an ECG and echo. You have images to show?
Yes, sir. The
Yeah, so
ECG
go ahead and just show the post-lytic ECG and then we can look at the echo if you want to show, if you have images.
Sir, make the Danji as co-host for this.
Please do that. So, chalo, suppose his ECG is okay, he's pain-free. This patient, you want to do angiogram, you will not do angiogram.
Yes, sir. We can do up to any patient following thrombolysis 3 to 24 hours after this. We can do an elective angiogram so that one third
Kaun
of
sa
the.
level of evidence, kaun sa guideline?
Sir, it's a class 2-year recommendation as per this American guidelines.
Not a routine angiogram, right? Then you every MI gets an angiogram. Class 1 to nahi hai na.
Class 1 is a class 2-year recommendations. As per the
So what
capital
is class
trial
1
and
indication for an MI to get an angiogram?
so after thrombolysis, sir.
Yes, after thrombolysis.
So after thrombolysis, if the patient in acute heart failure or cardiogenic shock, or if the patient having moderate to high ischemic burden, or if the patient having spontaneous or easily provoked myocardial ischemia. These are the 3 indications for
One more indication, ongoing angina, no?
spontaneous or
ongoing
easily
angina,
provoked
can you-
myocardial ischemia. These 3.
Ischemia, correct. So if you can document ischemia in form of always imaging or something else, or always stress or...
Yes, sir. We can do a dopamine stress echo.
No. Acute MI, you do use stress, dopamine stress.
We'll never do it.
We can do on certain what patients acute.
कैसे कहते हैं ongoing ischemia? What are the various criteria? It's an acute MI. You have thrombolized after 1.5 hours. After 2 hours, you realize that there is ongoing ischemia. You are failed in thrombolysis.
Criteria.
Failed thrombolysis. If you have the failed thrombolysis also.
Criteria.
Criteria. वही तो पूछ रहे हैं डॉक्टर को.
If the failed thrombolysis is less than 50% of ST segment resolution, or if the patient having ongoing
50
pain,
or 70?
so 50 in the limb leads and 70% in chest leads. Actual resolution should be ST
Between
segment.
50 to 70, it's intermediate, right? More than 70 is always successful. Less than 50 is always unsuccessful. 50 to 70 intermediate, again, you go by the limb and the chest leads. What is ischemia at a distance?
Sir, yeah, it is a reciprocal changes that occur in a patient with any MI changes. For example, in a patient with inferior wall MI, the anterior lead showing ischemic changes of ST segment depressed T wave inversion. That is the ischemia at distance.
Any scoring system that you know from ECG to predict amount of myocardial damage that has ensued?
Sir, one is Aldrich scoring system is there.
Correct, Aldrich scoring, correct.
Danji, एक बार screen share करो ना.
तुम्हें स्टॉप करना पड़ेगा. You have to stop.
Stop video.
You have to
Stop
stop.
share. Okay. Thanks.
Mohit, we can go for 15 minutes more.
I think, sir, you can continue, sir. No problem. Go ahead.
So what are you looking at in this ECG before it shows? Yeah, so this is pre, and then can you show the post, please?
Post thrombolysis.
Okay.
In post thrombolysis, we have developed the ECG with QS complex.
Show us the pre-thrombolysis. That is very important.
Where is the occlusion? You have taken this patient angiogram and you want to flaunt your skills and you want to tell your fellows, देखो इसको इस branch और इस branch के बीच में occlusion निकलेगा और मैं वहाँ stent लगाऊंगा. Stenosis in percentage is going to be this much and this is where it is occluded. Tell me where it is.
Sir, actually,
Localized.
I didn't have the TCG where the
No,
AVR is
now. Tell me now. Where is the occlusion now? I'm asking you.
sir, if the AVR is showing some elevation
No,
and
this
AVR,
this ECG. Where is the expected occlusion?
so it will be
Before
probably
septal, between septal and diagonal, septal beyond diagonal, proximal, ostial. I've given you a clue. This is how you localize, right?
yes, sir, yes, sir.
Yeah.
So
Is it
you are
ostial? Yes or no?
ostium, it is no, so AVR showing
Yo,
nothing.
so
ST
no,
segment
correct.
only.
Then between septal and diagonal,
Sir, if it is distal to septal, the patient will have an AVR elevation and AVL will be depressed, sir.
so it's not between septal and diagonal, correct?
Yes, sir.
And distal to diagonal?
So distal to diagonal will have some
So
depression
where is
in
this?
AVL.
This is
We'll have
where.
depression in AVL. It is also not seen. But one ECG, I didn't see that they are having AVR elevation in the ECG. Outside ECG of that outside
So
government
show me
hospital.
only this ECG. Tell me, if this is an ECG at the time of presentation, it is a large myocardium at risk or a small myocardium at risk.
Yes, sir. If the patient have 1, 2, 3, 4, as almost 5 leads having showing the ST segment elevation, so it is considered to be a significant ischemic risk when compared to the.
If you have a distal LED occlusion versus you have a proximal LED occlusion, in which the ECG is more scary.
So if
Kya
the
bolte?
distal
What
LED
pattern is it
occlusion
called?
will, if the distal LED occlusion will have sometimes wraparound LED where the 2,3F will also be elevated in this patient.
No,
Is it always wraparound? Again, that's a big question you opened up, sir. Sir will tell you all electrical vectors of it. You know, there is a big paper again on Indian Heart Journal which talks about why you get ST elevation in 2-3 and AVF in a patient with anterior wall MI. Is it the wraparound? Is it the septal? Or is it the vector? There are 3 papers on it, including one in the JAC, which talks about that it is not the wraparound, neither it is the septal, it is something else. So you should read that also. But iska batao mujhe. What is that pattern which sir is asking? Very scary looking ECG. Also called as tombstone pattern. Tombstone. What is that?
So tombstone appearance is almost the patient will having almost symmetric ST segment elevation in all the leads with small R with the prominent. It indicates that patient having extensive anterior wall MI conditions. It
So
will
tell
be
me ECG changes which are not ST elevation but are considered as equivalent to ST elevation MI. 2 signs, 2 named signs.
One is the D winter T waves can be seen, sir.
Correct. So there is no ST elevation. D winters, you can have one. Second, somebody's sign again. So one is D winter sign, other is?
Semi equivalence.
there is something when V1 lead V1.
So posterior wall MI changes can be seen, sir, where the patient will have positive R wave with ST segment depression along with some T wave inversion in the V1 to V3. That
And
will be
third is
seen along with Wellen T waves can be
Valence sign, correct. Valence. Valence sign. You should remember that. Okay. So next, can you show the ST next lysis? And then next.
So this is the ECG after 12 hours where the patient has developed.
So what has happened? Go back to the previous ECG and look at now. Do you think something has changed?
So now the patient developed T wave inversions along with
Is it normal or abnormal now? Go to the next one. See here, T is upright, Qs have come, and now you're getting T inversion. Is it okay, or you think this is scary?
No, sir, it's suggestive of the general T wave was to return to normal in the patient, sir, but it has been persistent T wave inversions.
Now, what is the natural course of T wave in acute MI?
T wave will be hyperacute in the initial hyperacute phase,
Yes.
where the T waves will be tall, broad, and symmetric waves. Then the T wave will gradually, in evolved phase, the T wave will be getting inverted, and in chronic stabilized phase, the T wave will returns to normal, sir.
Yes. So the T wave inversion is not a scary sign.
Next.
So X-ray didn't show anything normal or significant.
Of course, no COVID-like infiltrates. Fine.
What abnormality you think you can get in X-ray? Stable patient, can you get some abnormality or no?
If the atherosclerotic signs can be
After
patient having
MI, suppose after MI 10 days, you have done an X-ray. Patient is not having much symptoms, some chest pain.
so pericarditis to causing pericardial effusion
क्या
can
कहते हैं उसको? क्या कहते हैं?
Dressler syndrome. Sir.
Dressler syndrome. Can get it.
Treatment of choice, Dresslers.
So it is steroids we can give.
No. Don't mention like that. No, steroids, colchicine, sub out, aspirin. Bro,
Sorry, aspirin.
yeah, so when we were preparing for DM, it was steroid and colchicine. New paper doesn't talk about only aspirin. That is the dose. Every 4 hourly. Don't make that mistake. That is a very commonly made mistake. People talk about steroids and colchicine.
Tell me one more concept. If you give 3 hourly or 4 hourly aspirin versus 1 OD aspirin, if platelet inhibition is going to be more, or there's a plateau with a dose of aspirin? Suppose I give 2 gram of aspirin versus 325 gram of aspirin.
And
What?
75.
Sir, it will get a plateau effect after a dose of
325.
325.
Yes. And what is the recommended dose post PCI of aspirin?
75 mg, sir.
No.
75 to 100 mg, sir.
No, absolutely no. Post PCI recommended dose still is 325 milligram for some time. Now you give 75 milligram or not? Only with one drug you give 30.
Plateau with a lower dose. Otherwise, it is all 325. What sir is saying.
If you go and read the guidelines,
PCA, sir.
yes, only with ticagrelor they say give 75 milligram. A classical teaching.
81 in
read,
they don't have 75, so they used 81 and 100. So अपने यहाँ वो भी नहीं मिलता है. So we use 75. Okay, you've ruled out mechanical issues with the echo. Can you go next slide? Okay. So are you happy now? Does this echo help you in choosing an angio versus not choosing an angio? Do you think that RWMA, if it is present, is good enough an indication for you to go invasive?
Yes, sir. If the
You've
patient,
thrombolized, you're doing an echo, EF is showing say the 45% and apical septum anterior wall is hypokinetic. Will you go in or no? Immediate post lysis.
so immediate post lysis we can go because some amount of standard myocardium can also be present in this.
No. What is stunning? Will LV always return to normal or there can be some stunning?
The standard myocardium will be same, sir. Where the
Yes, it
patient
can be, no? So that need not always mean that it's not.
post
What is what trial?
Sir, occluded artery trial where these patients after 24 hours after the 100% occluded artery, if you open it after 24 hours, the chance of there is no benefit associated with increased risk of reinfarction with
24 hours?
24 hours after the occluded arteries.
नहीं, are you sure 24 hours है? We always talk now in cath lab. It's 72 hours, 28 days, no?
3 days, na?
वो trial पे गड़बड़ मत करो यार.
Yeah, what trial should know 3 days. That's why abhi to you told na we'll do angio within 3 days. We discussed that, no? 2B indication.
3 to 24 hours.
No, study was to enroll patients from 24 hours onwards, and they found out that those who were opened and occluded artery beyond 3 days had no benefit. So up to 3 days you can do. That is what the trial was. So trial included beyond 24 hours, but benefit was up to 3 days. Of a totally occluded artery, not a partially occluded, total occluded artery, 100% occluded artery. Okay.
Now you have seen the echo on 3rd day. There is a regional wall motion abnormality. Or 4th day, what are the indication in which you see PCI not going to benefit on echo?
Sir, if I am showing that the myocardium thickness has been reduced,
Thickness.
or if the patient, akinetic LAD will, if akinetic is.
What do you see in that? How will you define? A thin myocardium, usually it is a dead myocardium. So how it is defined? On echo that this is a thin myocardium, there is akinesia, it is not going to improve versus normal preserved myocardium with akinesia going to improve.
Sir, if it is akinetic, if akinesia means if the contraction of the myocardium is less than 10% during the systole, then another one will be the thickness. If you see the septal thickness, if it is less than 0.6, it will be chances of viability is unlikely in those myocardiums.
What more? Suppose those are dyskinetic myocardium. What are the chances of recovery of dyskinetic myocardium versus akinetic myocardium? Until how long the recovery can happen? Post successful thrombolysis of post primary PCI.
Post successful thrombolysis, the patient can have this standard myocardium up to 1 week, sir. We can wait for 1 week.
अगर 1 week होता तो फिर हम ICD सबको डाल देते 15 दिन बाद, अगर जिसका EF 30% होता.
You have to wait for 42 days.
Usually 6 weeks and up to 3 months. The other surgeon has seen it is up to 1 year. Also, there is a recovery. So it can go up. The average improves if it has to improve. It will improve within 3 months. Suppose you have a primary VT. Just on after 9 hours of successful thrombolysis, how will you approach these patients?
We'll keep on conservative only, sir. Within 48 hours following it, there is no need of getting an ICD, sir. Up to 48 hours following the time.
How will you define a primary VT versus a secondary VT? There are specific definitions because it's very crucial for a patient.
So primary VT means any patient who had after the onset of symptoms, after that up to the 48 hours after the revascularization or after failing reperfusion. Up to 48 hours, it is considered to be primary VT. From the third date to secondary VT, it will be after this.
And what do you mean by VT storm? How will it be defined?
Patient having a consecutive VT episodes lasting for almost 24 hours.
24 hours.
Yes, sir. Lasting
too long.
greater than a day, not resolve the treatment. I don't exactly.
And what is the treatment of VT storm during MI? क्या करोगे अगर recurrent VT हो रहा?
Recurrent VT, the first I can give in a shock only. This is shock I can give.
Shock
Then
stabilize, shock कर दिया, okay. What drug you will like to give?
I can give lignocaine, I can give an amiodarone, I can.
नहीं अब तुमको DM cardiology कर रहे हो, अब तुमको specific बताना पड़ेगा. What you want to give first? What the study shows? Versus if there is a VT storm, what more you will add? You have to tell. Yeah, you cannot say lignocaine दे देंगे, amiodarone दे देंगे. What are the guidelines? First, what will you give? Second, what will you give? If it is not controlled, third, what will you give? It is a lignocaine or it is amiodarone, which is recommended now. And what is the role of beta blocker in this situation?
Beta blockers will also be given. But I don't know
And which is important? It's a monomorphic VT important, a polymorphic VT, which is more important. Suppose after 9 hours, patient has a polymorphic VT. What will you will take patient to cath lab or not? Patient is stable, you are successfully thrombolized, absolutely stable, no chest pain, and in 9 hours he have a polymorphic VT. Versus he has a monomorphic VT.
monomorphic VT. Polymorphic will be most likely due to metabolic cause or ischemic
एक
cause.
metabolic हो गया और दूसरा
It may be due to the ischemia also, sir. But
ischemia also good. So treating VTs also has a lot of differential diagnosis in acute MI. This type of VT when it has occurred, and what is the role of beta blocker in management of VT storm during acute MI? Should be given, should not be given.
can be given, but how much? I don't know.
And what are the other causes? Can you see on ECG something? And which happens during ischemia or acute MI?
Long QT can be.
What?
If the patient
सही
long,
बोला ना?
so long QT associated with VT, then I have
Not
to,
associated. But ischemia can lead to long QT.
yes, sir. Ischemia can also
One
cause
of
long
the cause
QT.
of long QT. So if you have a long QT, you have seen an post-MI patient, you have a long QT, you have a VT. Which drug you will prefer?
Then I can give a beta blocker, sir.
Yes. In that situation, the beta blocker is always preferred. What is the role of magnesium during MI? And what is the cutoff value of potassium during MI?
So potassium should be greater than 3.5, sir.
When patient is having VT, you will keep 3.5 greater than or more than 4. You have to keep more than 4.
Which study?
Study. Nothing.
Any negative antiarrhythmic study you know of in VT in MI? One beta blocker only. Half beta blocker, half. Sotalol? SWOT trial, what was the outcome?
Sotalol.
No benefit, increased mortality, no? That's why the classical beta blockers, not the Sotalol kind of a beta blocker, which is both class 3. So that is what sir is saying, no? Long QT, that's why you're worried. You can't even use a beta blocker which is having any issue on QT.
And सबसे important question तुम्हें पूछा जाएगा, what is the current role of beta blocker during acute MI?
IV oral.
क्या दोगे, क्या है current role है, दोगे कि नहीं दोगे? What is the current role?
You can give the beta blockers in at present in acute MI. If the patient is hemodynamically stable, we can start as early as within 24 hours.
IV.
IV, you should be seen only if the patient having
100,
hypertension.
blood pressure 180. Want to give IV?
Now we can use if the heart rate is less than 60.
Comet CCS2. Comet CCS, what was the outcome? No benefit IV, worsens the heart failure. Don't give IV, just be oral is good enough. Oral is good enough.
And what are trial which favor that you should give oral, and what is that trial suggests? Oral should be given immediately, or it can be given.
Very old trial.
Comet trial.
No, you go still back. When we were even residents, I think Serbs must be preparing for D.
They have never given immediate oral beta blocker.
Huh? Which one? The trial is called beta blocker heart attack trial. Now you know the name. Now can you give the acronym?
Heart
trial, no? Heart BHA, heart trial. You heard of? That's when before life trial came, everybody used to be a beta blocker fan, no?
And they have given beta blocker up to 28 days. So immediate beta blocker until there is some other compelling indication like increased heart rate, patient is stable, high blood pressure. You should avoid beta blocker during initial phase of MI. And the second important question, which is always asked, what is the role of heparin during acute MI? When you will give, what is the dose recommended in thrombolysis during PCI?
So heparin should be given 60 units per kg bolus dose with the maximum dosage of 4,000 units per 4,000 units. Loading dose should be given.
No. These are the common questions which you are asked and everybody fails. At what time you will give heparin? Just after giving clopidogrel and atorvastatin, you will give heparin. After thrombolysis, you will give heparin. There's a difference between STK versus newer thrombolytic. When you are planning for primary PCI, when you will give heparin, there's everything is very specifically described in guidelines.
Heparin dosage in thrombolysis is 60.
So you should know these all when you have to give. So when you are presenting your CAD patient, especially in acute MI patient, these are very, very important things. If you have given streptokinase, what is the role of heparin? If you have given telecnate-place, atyl-place, what is the role of heparin? And which heparin is tried? Which heparin is studied the most?
So unfractured heparin is the one that it studied most. Then in extractimi 25 trial, we studied the low molecular heparins.
Which low molecular weight heparin?
Enoxaparins.
I'll give you the name of the trial. Essence trial and TIMI 11B.
TIMI 11B.
And Create also studied one of them. They found no benefit. So the other was removed and this continued to have 2 benefits. So Create had which heparin, low molecular weight heparin? Rabiparin. Negative outcome. Enoxaparin, Essence, and TIMI 11B. Positive outcome. And of course, you talked about extractimi. Sir, I think it's already 7:30.
Yes.
इनका YouTube video पे भी थोड़ा issue रहेगा. So thank you very much.
Thank you.
Dr. Mohit?
Very much.
The important thing, you should note down all the questions which are being asked.
Yes, sir.
You can search answer in your in the book, but you should know what questions are generally being asked when you are presenting these cases.
And the challenge is that coronary artery disease is such a wide spectrum. Actually, you don't know where you will be pulled along.
Yeah.
And this is also one of the major cases. And lately, when we have been kept, so you can be just pulled anywhere. You know, you may be the trials and everything, antiplatelet therapy. You can go deep into the antiplatelet, the combinations, the side effects, the complications of MI. So
I think the most important thing is there are no findings most of the times.
That's why
So
they're all trials.
more of
theoretical
theory,
discussion. Yeah.
and this is actually in the new age rheumatic heart disease, which gives the bread and butter for all the cardiologists. So they should know everything. There is no doubt about it.
I always recommend them that you should read at least one guideline.
Yes.
For management of STMI, if you read a guideline, 90% time you are able to give all the answers, especially management part. Because if you don't answer, it gives a very bad impression that you don't know when to give heparin, when to give atorvastatin, in which doses, in which trial. So when we are presenting the case of ACS, you should be very best of guidelines. Very good. But ma'am, you have done a very good job. ऐसा नहीं है. We have asked pretty hard questions.
Yes.
And Dr. Kamal, I think 30% of his question I cannot answer. So don't worry that I know his questions are always very good. So we should always write it down and see it. Very good.
Thank you, sir.
Thank you so much, sir. Thank you, Ajay. You did a great job. That's fine, and learning is an ongoing process. So I think all our other residents also will be motivated to read more, and all other people who have joined, more than 300 people already online, should be motivated to read more. Come on, go ahead, read your brown world, get onto your basics again. It will be a great for you. And I also thank Dr. Rakesh sir and Dr. Kamal Sharma. Always a pleasure to have you, sir. And हमारी भी knowledge बढ़ता है. I think it's always a great learning for all of us. You know, it's such a wide spectrum, and you are right, sir, that most of the questions sometimes we even can't answer. So it's a mutual learning for all of us. And thank you so much, and we'll keep on bugging you, sir, for the future sessions in the interest. And thank you, Kamal sir. Thank you, Rakesh sir. Sumod sir, thank you so much. Thank you.
Thank you, sir.
Thank you, all the residents, you know, all the budding cardiologists. Have a great evening. And next week, we'll be coming up with another case with new set of examiners and have a wonderful deep dive into another discussion. Thank you, Intas, for providing this platform. Thank you. Good evening.
Thank you, sir, and good evening.